So there was a very interesting session today on rare GU cancers, and my role was to discuss GU cancer variant histology in bladder cancer. This field remains very challenging because these are rare types of cancers, and we talked about that in terms of treatment modalities as well. We're struggling to have better outcomes for these patients because often these patients are excluded from most of the clinical trials, which are focused on urothelial cancer, which is a more common type of bladder cancer. But for these 10 to 20% of these cases who are more where variant histology is predominant, there are not many trials for these patients. So today we talked about various subhistologies and variant histologies of bladder cancer, which are predominant variant histology with some urothelial cell components as well, and some are completely variant histology with no urothelial cells at all. So today really we went through that, discussed those different histologies, discussed the challenges, and we also discussed how globally we should be doing concerted efforts to work together and try and move this field forward as what we have done in urothelial cancers over the last decade, where we are seeing significant improvement in survival. We talked about a very young patient who unfortunately we lost literally a few weeks ago. We talked about how he presented to us literally 9 months ago, had some chemotherapy, then had surgery, but unfortunately within 6 weeks of surgery the patient relapsed with the disease and passed away a few weeks ago. So it was just to show and highlight, and many of us in the audience, many of my colleagues after the talk also shared that they have a number of patients where they are seeing very poor and dismal outcomes. So really the key was how we work together and try and develop new clinical trials and studies to change the field of rare variant histology of bladder cancer to improve the outcome for our patients. It again depends on which variant. There are a number of variant histologies in bladder cancers like squamous cell cancer, plasmacytoid cancer, sarcomatoid cancer. These are different types of, we talked about over 12 different variant histologies in bladder cancer, and micropapillary bladder cancer. The outcomes are different for different cancers. Quite often we see challenging things are like squamous cell cancer, stage by stage outcomes are very similar, but unfortunately they present very late. So because of the late presentation, sometimes they are not fit for further systemic treatments. Quite often they're presenting with metastatic disease, with very poor with comorbidities and their fitness levels, which does not allow us to use more chemotherapy. So survival figures remain low. We talked about a series where in the SEER databases where localized small cell bladder cancer, when a retrospective analysis showed that actually if they had chemotherapy followed by surgery, about 40%, 46% of the patients a median survival 46 months versus 22 to 23 months if they had concurrent chemoradiotherapy. And again, there will be selection bias within that because it's a retrospective series, and that's why the key focus is to try and bring more trials into it. Another thing which I talked about, which is from the UNITE study, the North American consortium looking at use of enfortumab vedotin, and very clearly we saw that actually patients who were treated with EV, with predominant urothelial cancer with some variant histology, their response rate was much higher compared to those with predominant variant histology. So again, that tells you that we need to do huge amount of research, huge amount of effort to get the best for these patients. Another thing which I highlighted today was based on a UK study which we are running called Abacus 2, led by Tom Powles. Bernadette Sabdos, one of our colleagues, presented it last year. And the key thing to show in that during my talk today was to say that with a central review of pathology, we saw that actually the classification of bladder tumor or the variant histology of the bladder tumor, some of them changed after central review. So one of the discussions we had and in my talk, I talked about how important it is to have a very specialist MDT and very specialist uropathologist who is focused on bladder cancer and GU cancers and perhaps more on bladder cancer, so that we can take these rare histologies and move things forward. Because there is still debates around the diagnostics, there are debates about where we call it predominant, if it's a small cell variant histology of 20 or 30%, and urothelial cells 60 or 70%, Do we treat them as urothelial cancer, or do we treat them as small cell bladder cancer? So lots of these things are questions and something that we need to debate around, and we need to move the field forward by doing clinical trials. Because by treating these patients within clinical trials, we will be able to move the field forward and find out, for example, in sarcomatoid subtype of bladder cancer, we have seen some good responses with immune checkpoint inhibitors, both in ABACUS-2 and within the UNITE database as well. So, sort of in the UNITE, for example, with EV, in terms of response rates, you need to be looking at different subtypes of bladder cancer and see that. So within ABACUS-2, as I said, that you saw that with the use of 2 cycles of neoadjuvant atezolizumab as a window of opportunity study before cystectomy, path-CR rates were high in sarcomatoid bladder cancer, while in squamous cell bladder cancer we did not see that much response. We saw only 1 out of 12 cases. So again, these are small numbers. The key thing will be that globally we all work together. We bring real-world data set together as well to learn from each other's cases and help us to design a clinical trial which reflects what is required on the ground.